do want to say a few things. You know, when we talk about primary adrenal insufficiency, the signs and symptoms really depend on a few things. The rate, how fast are your adrenals being destroyed? Is it acute, subacute, is it chronic? The extent of the loss of adrenal function. Is this someone where there's a partial damage to the gland? Is it a full gland has been destroyed? This is going to be important. And really another thing that's important is, well, what about those mineralocorticoids? Meaning, what about the aldosterone? When we talk about what really regulates potassium levels in the body, it's aldosterone. And of course, what does aldosterone do, everyone? It makes you reabsorb the sodium and you dump out potassium in the urine, and hydrogen ion gets dumped out in the urine. So if you have, no aldosterone levels, you're going to have a very high potassium. You got to be careful, And of course, the stress. What kind of physical stress are you going under? Are you undergoing a surgery? Did you undergo a motor vehicle accident? All these things factored in will tell you what are your signs and symptoms of adrenal insufficiency. So the onset of adrenal insufficiency is often very gradual. I think many people assume you say adrenal insufficiency, it has to be an adrenal crisis. But many people go undetected because it's very gradual until, unfortunately, an illness comes up or some kind of stress comes up, and then you get the adrenal crisis. So when we talk about adrenal crisis, don't get me wrong, it's in bolded red. It is a life-threatening condition, and it really comes down to there's just not enough cortisol. So I put this picture here because when we talk about, the adrenal gland, there's the cortex, and of course there's the medulla. And we talk about, the cortex, it's subdivided into the zona glomerulosa, which makes aldosterone. The zona fasciculata is the biggest chunk here, and it makes cortisol, influenced by ACTH. And of course, you have the zona reticularis that makes the androgens, And of course, if you have an adrenal crisis, the main thing we think about is shock. I usually give this talk when I'm hanging out in the medical ICU. But as I said, you could have a gradual adrenal insufficiency before it leads into right adrenal crisis. So think about anorexia. You get some nauseated, vomiting, some poorly defined abdominal pain, weakness, fatigue, lethargy. And of course, now we're getting severe with confusion, of course, coma. So the most common cause of a primary adrenal insufficiency, otherwise known as Addison's disease, is autoimmune. So you get an autoimmune destruction of all the layers of that, adrenal cortex, which is subdivided into zona glomerulosa, fasciculata, and reticularis. And approximately 90% of patients are going to have antibodies to something called 21-hydroxylase antibodies. So that's going to be a nice little board poll right there. What antibodies are going to be ordered, or would you order? Those 21-hydroxylase antibodies. Now, 50% of people who develop autoimmune adrenal insufficiency develop another autoimmune endocrine disorder in their lifetimes, such as primary hypothyroidism. I think you're probably going to assume I'm thinking about a Hashimoto's thyroiditis. They have a lot of autoantibodies there. Primary ovarian insufficiency, hypoparathyroidism, of course, type 1 diabetes that have these anti-islet cell antibodies. And if you have a combination of primary adrenal insufficiency combined with any one of these, they call it autoimmune polyglandular syndrome. And a nice little pearl for your boards is if you have this autoimmune polyglandular syndrome, it's associated with the skin lesion vitiligo. So please, that would be a great question for your board exams. And also remember, because it's associated with other autoimmune diseases, why not celiac disease, which is a great topic on boards in general. And I know celiac disease was it anti-gliadin antibodies, anti-endomysial antibodies, anti-transglutaminase antibodies. These are IgA antibodies, by the way. So it doesn't surprise me. And the classic skin lesion with celiac is dermatitis herpetiformis. So primary adrenal insufficiency can also be caused when you get a bad infection, infiltrated disorders like sarcoid, hemochromatosis, even amyloid, of course, unfortunately, even lymphoma. And of course, right here, I put some bilateral hilar fullness. And of course, in the right history, right physical, this could be a sarcoid patient. Metastatic disease involving the adrenals rarely leads to adrenal insufficiency. even if both glands are involved, just to mention that. But one thing I do want to mention, this is maybe more medical ICU, if you get bilateral adrenal hemorrhage, that of course that can present as an acute adrenal insufficiency. And you could consider that if it's unexpected hypotension develops. What would be risk factors for developing this? Well, if you're anticoagulating someone develops DIC, disseminated intravascular coagulopathy. Sepsis can definitely do that. If you have protein C deficiency, it can happen. And I put this here specifically just in case we have some listeners that just really love their USMLE Step 1. I don't know if anyone remembers Waterhouse-Friderichsen syndrome. I've always memorized it, but never seen it. Is adrenal failure due to bleeding into the adrenal glands caused by several bacterial infections. The one that always jumps to my mind is people who have Neisseria meningitidis. So I had to put that one there, just had to. So clinical features, primary adrenal insufficiency is a life-threatening disorder that often presents with initially an insidious and gradual onset. So therefore making a diagnosis can be challenging. It may also present as adrenal crisis after an acute illness, or sometimes maybe you're initiating thyroid hormone replacement and you didn't realize the patient also had adrenal insufficiency, and that can cause it. And that's why rule of thumb is that you always replace the cortisol first before you replace the thyroid. And that combination of hypothyroidism and adrenal insufficiency, sometimes referred to as the Schmidt syndrome. And yes, cortisol first, then the thyroid. And when you work these patients up, since the problem is primary in the adrenals, ACTH levels should be high in these cases. And one thing we commonly think about, but it's not present in all patients, is hyperpigmentation. I think many of us know where I'm going with this. Think about the stimulation of melanocytes by high levels of melanocyte stimulating hormone, which is very similar to ACTH. And really that darkening, hyperpigmenting of the skin is one of those hallmarks of primary AI. So how do you work these patients up, everyone? Well, I would say 3 things for your boards. Number 1, check a 8 a.m. cortisol level. And remember, when we think about cortisol, it's diurnal. It's different in the day, different in the night. Cortisol is going to be the highest in the morning. So if you think you're deficient of it, it should be low in the morning. Then I would check an ACTH level to see if it's going to be primary or secondary. If it's going to be primary, ACTH levels are going to be super duper high. If it's going to be secondary, they're going to be low. And sometimes there is, if you want to do a more conclusive test, you could do what's called ACTH stimulation test. Many of you call it a cosentropin stimulation test in the right setting. I'll tell you the right setting is probably not going to be the medical ICU. So primary AI is confirmed by a combination of low serum cortisol, elevated ACTH levels, and that evaluation will include measuring some of these 21 hydroxylate antibodies we talked about. And you can consider CT of the adrenals, especially if you don't see or don't have a positive antibody and you're wondering if something else is causing the problem with the adrenal gland. So how do you treat them? Well, you're going to treat those with both glucocorticoids and mineralocorticoids. And that's going to be a key board pearl there if they ask you. You want to give both. You want to give the steroid and the aldosterone. And the preferred glucocorticoid is hydrocortisone because you could do that 3 times a day. And even though many of us will just default to saying, here's your prednisone, because you can use it once a day, it's more convenient. But the whole principle is that, cortisol is diurnal. It's going to be high in the morning, low at night, that you want to kind of mimic what your adrenal should be naturally doing. Be careful with over-replacement. Of course, these patients can develop a Cushing syndrome because you're giving them too much cortisol. And mineralocorticoid replacement is usually once daily. And the classic thing we use is fludrocortisone is what we use. So it's important that, patients can have a kind of a sick day rules. So unfortunately, if they do develop adrenal crisis, they should wear a medical alert tag. So if they were found down, the importance of them receiving steroids is such an emergency in these patients. And these patients should be prescribed an emergency kit with high dose steroids that can be given intramuscularly in these patients. And just to make sure that I don't forget to tell you this, always if you're worried about hypothyroidism, please give the steroid first before you're going to replace the thyroid. I did mention earlier in my lecture there's something called the Schmidt syndrome, which is the combination of autoimmune adrenal insufficiency and autoimmune hypothyroidism, plus or minus type 1 diabetes. They call that the Schmidt syndrome. So with that being said, I hope no one's going to be upset, but can I just do maybe 3 questions? I know I love taking my time, but I really want to show you how you integrate this. So there's a 39-year-old woman is evaluated for fatigue and abdominal pain for 3 months duration. She has lost weight 5 pounds during that time. She has no other medical problems and takes no meds. On exam, her blood pressure is 110/70 sitting, and it goes down to 90/60 when standing. Sounds like she's orthostatic. Her heart rate is 70 sitting, goes up to 88 when standing. Remaining vitals are normal. Her BMI is 19. She has intensely tan skin, that's even in bolded red, and hyperpigmentation of the buccal mucosa and palmar creases. It's hyperpigmented. Visual field testing is normal. They do some labs. Sodium is low, potassium is high. Sounds like there's no aldosterone. The morning cortisol is pretty low at 2.1. It's pretty low. And the ACTH level seems to be pretty high. Low cortisol, high ACTH, that is primary adrenal insufficiency. Patient is orthostatic and pigmented. Oh boy. Which of the following is the most appropriate next step in management? Let's do these together because of time's sake. Does this patient need a cosyntropin stim test to prove what's going on here? I don't think so. And I think, speaking to guidelines, when your morning 8 a.m. cortisol is 2 or less, that in itself, along with the symptoms, confirms the diagnosis. I don't think you need a stim after that. And this patient's symptomatic. It needs to be treated anyway. If I were to treat, I probably would use, a dexamethasone if I still was being very stubborn and I wanted to do an ACTH stimulation test. But I don't think you need to do one. I'm not going to go with A. I'm sorry. B, hydrocortisone plus fludrocortisone. I see manifestations of both aldosterone deficiency as well as glucocorticoid. You're really going to have to twist my arm not to do that. And this is primary. MRI of the pituitary, I don't think that's necessary. The ACTH level is going to be very high over here. There's darkening of the skin. There's no eye findings. I'm not going to pick C. Prednisone, once again, I need to address the aldosterone. I know some people will say, but isn't there a little mineralocorticoid with prednisone? There probably is, but just not enough, especially in someone who's hyperkalemic. Measure serum aldosterone levels. I don't think this is appropriate in this case. It seems insufficient. It's not as if the patient's having a Conn syndrome or anything like that. I got to pick B, everyone. I hope we're on the same page. And our answer is B. And I did mention already how to be treated. You want to use things like eventually hydrocortisone, kind of in 2 to 3 times per day, to kind of go with the diurnal variation of the glucocorticoid. And this one probably is going to be an autoimmune because that's one of the most common things that we see. And B is definitely the right answer here. Let's do 2 more. I think I can squeeze them in, everyone. 62-year-old man is evaluated in the hospital for several hours of nausea, lightheadedness, and back and abdominal pain. He underwent uncomplicated mechanical aortic valve replacement 3 days ago. He's been doing pretty good post-op until his current symptoms, which is nausea, lightheadedness, back and abdominal pain. He had a history of hypothyroidism in the past. Meds are unfractionated heparin because he just got some kind of aortic valve replacement. He's on levothyroxine for his hypothyroidism, and he has some pain meds and oxycodone. On exam, he is 99 degrees for the temp. His blood pressure is bolded at 80/50. That's not good. He's hypotensive and tachy at 110. Not tachypnic yet at 18. BMI is 26. Remainder of the chest exam shows clean, dry sternal wound. Cardiac exam reveals tachycardia and a mechanical S2 now because he has a mechanical aortic valve. There is no pain with palpation of the abdomen or low back, but his skin pigmentation is totally normal, so he does not have pigmented skin. All right. Labs, it looks like his hemoglobin is now 7.3, which is already low, and it was actually 9, so it dropped almost 2 grams. Leukocyte count's 11,000. PTT is elevated at 70, which is normal because patients on unfractionated heparin, which affects the intrinsic pathway. So the PTT is 70. Creatinine is 1.0, which is normal. Sodium is 130, which is low. Potassium is high at 6. And the cortisol is low, less than 2. Which of the following is the most likely diagnosis over here? So let me take a look at this. Is this going to be someone who just knocked off his pituitary apoplexy? Did he bleed into his pituitary? Well, I can tell you one thing. I'm sure this gentleman didn't have a Sheehan syndrome, which is seen in, of course, in pregnant in women after they deliver and you infarct. This is not pituitary apoplexy, anyone. I think the problem here is really focusing on the adrenals. Is this opioid-induced adrenal insufficiency? Probably not, because opioids don't really induce adrenal insufficiency, Is this an autoimmune adrenalitis? Well, I think the adrenals are gone, but does this seem like something that happened that was kind of building up? I would probably say no. I mean, the skin pigmentation is normal, and he never had any issues. I know he had that history of, hypothyroidism there, but, there's no indication that this is going to be an autoimmune adrenalitis, especially with the hemoglobin going down. Patients on unfractionated heparin. This really sounds like an acute bilateral hemorrhage. Suddenly post-op, he develops this. This kind of makes sense with the reasons what I said. I wouldn't pick anything else. So the answer here is going to be what? B as in boy, for all the reasons we talked about. So I know many of you are just waiting to get off, and I apologize. Can I just do one last one and we can call it a day? All right. So this is a 65-year-old woman is admitted to the hospital for fatigue and weakness over the last 1 to 2 weeks. Medical history is significant for hypertension, type 2 diabetes, and I couldn't resist it, everyone. You can roll your eyes. Rheumatoid arthritis. I always like to integrate. I know we just talked about rheumatoid arthritis. For the past 3 months, patient has been treated with methotrexate. I always say it's the cornerstone. Unfortunately, prednisone. Because of inadequate control, what a surprise, they added a biologic, TNF inhibitor and etanercept to the regimen, which was added 2 weeks ago. At that time, patient decided to just stop the prednisone because she was getting bruising of the skin. So current medications are methotrexate, which is a non-biological DMARD, a TNF inhibitor and etanercept, a CCB, amlodipine, folic acid because of the methotrexate, metformin, and aspirin. On exam, patient's blood pressure is 110/70 and 90/60 standing. Patient is orthostatic. Heart rate is 102 sitting and shoots up to 110 standing. Borderline orthostatic. Symmetrical synovial bogginess of the MCP joints and wrists are noted because her RA wasn't controlled. And once again, they got that morning cortisol level 2, number 2 or less, really indicative of what? Primary adrenal insufficiency, especially if the ACTH is high. But no matter what, this is definitely adrenal insufficiency here, no matter what, Which of the following is the most appropriate management? Oh boy, this is interesting. So choice A is hydrocortisone. Choice B is hydrocortisone and fludrocortisone. Choice C is perform an ACTH stimulation test, which I already said, when you have such a low morning cortisol in someone who's almost orthostatic, and there's a smoking gun here, right? Why is this happening to the patient? Patient was on prednisone, and what did this patient do? Just stopped it. And let me ask you this, class. Is it good to just stop your steroids, stop your prednisone cold turkey? No, we all know we need to taper that out. Give time for the adrenals to kind of get back in there. But she stopped it immediately, then developed orthostatic issues. So I don't doubt that she's adrenally insufficient. So I'm not going to do a C, perform an ACTH stimulation test. I'm not going to perform it even after I give steroids over here, even though I would like to give steroids. So it really comes down to A and B. So which one do you folks think is going to be the right answer? Who thinks it's going to be A, just give the hydrocortisone? All right, I'm just kind of pretending that I'm seeing everyone. Who says it's B, give the hydrocortisone and fludrocortisone? And the right answer here, everyone, is going to be A. What? What did Dr. Rush just do? Why is it just A? Because when we talk about someone who is going to be taking steroids, what type of adrenal insufficiency do you develop? Do you develop a primary or do you develop a secondary? And the answer is it's a secondary adrenal insufficiency. So if the problem is that when the pituitary sees all the steroids, it's not going to secrete ACTH, but the adrenal itself is still functioning. And when we talk about what's in charge of the mineralocorticoid, it's the renin-angiotensin system. So in this case, what do you really just need to replace? It's just the cortisol. So the answer is going to be A. So I put this right here. I apologize. I know you're mad at me. I put down USMLE step 1 throwback. Remember, is that when someone is taking, steroids, that they are going to cause a secondary adrenal insufficiency affecting low ACTH levels. But the renin-angiotensin system is still activated, so there's no need to give mineralocorticoid supplementation at this time. So, what are my beyond the pearls for this section of primary adrenal insufficiency? Most common cause of primary adrenal insufficiency is still autoimmune adrenalitis, leading to progressive mineralocorticoid, glucocorticoid, and adrenal androgen deficiency. Glucocorticoid and mineralocorticoid therapy are required for primary adrenal insufficiency. Don't get tricked by my question. Patients with adrenal insufficiency require instructions during a sick day. Okay, and don't forget that medical alert bracelet they need to be on. And with that being said, I know I went over about 10 minutes. I really hope everyone enjoyed this. The rheumatology section and the endocrine section, they're both very high yield for the board exams. And I really, truly hope to meet everyone in person one day. Good luck, everyone. It was nice having you to stay on this whole time.
All right, Dr. Raj. So it looks like we have 2 questions in our Q&A window.
Oh, there we are. So one just says are SSA DNA and single-stranded DNA and double-stranded DNA always positive in Sjogren's syndrome? Primary versus secondary Sjogren's, SS, or double-stranded DNA correlation? So the answer is no. Of course, right off the bat, when you say the word always, my answer is always no. It is unfortunate that in many of these autoimmune diseases, many of these rheum diseases, can you have the disease and be antibody negative any disease? The answer is yes. For example, rheumatoid arthritis. There is definitely something called seronegative rheumatoid arthritis, which is so hard to diagnose. And rheumatoid factor will be negative, anti-CCP will be negative, but they act just the same, And when we talk about, double-stranded DNA, I really think of a more specific antibody for lupus patients, But remember, when we talk about Sjogren's, there's primary and secondary. And secondary Sjogren's can be added on to rheumatoid arthritis, can be added on to lupus, even though I see it more commonly with rheumatoid arthritis. So this could be a patient with lupus and Sjogren's over there. So I think when you have a lupus patient, you could think about they really tend to have more of the positive ANA, which is based upon titer and pattern. And, those lupus patients tend to have more of the anti-double-stranded DNA in those cases. So our question I used was probably a combination of having some lupus and having Sjogren's at the same time. Hope that answered your question. For the boards, in the second primary Sjogren's syndrome patient vignette with pulmonary fibrosis, would the board want us to biopsy the lung prior to placing patient on immunosuppressive therapy, if that were an option? That's a really good one. Let me just say this. Love your questions, Hala, by the way, very much so. Is that, it's so hard to make a decision of what to do with many of these ILD patients. One of my passions is CT ILD, connective tissue ILD, but we really present those in a multidisciplinary setting with a rheumatologist and a pulmonologist, IR, surgeon. I'm not trying to hide away from the answer, you know what I mean? But you do want to choose what's the patient's age, what's the necessity, what are the side effects. But I will say this, especially when you're talking about Sjogren's, like this patient, especially talking about extraglandular Sjogren's, which isn't as common, and someone where you're going to commit them to systemic steroids or immunosuppression, I would be very strongly inclined to biopsy, and how we do that is also up to debate. whether it's going to be something as simple as doing a bronchoscopy and ruling out infections and other things before starting, or just looking for cell findings, seeing if it's the Pacific predominant, looking for eosinophils to confirm the right answer or not the right answer, or getting transbronchial biopsies. But nowadays, not to get too detailed, there's something called cryobiopsies. And I work with many amazingly smart interventional pulmonologists that will freeze areas and get bigger bites so they can get tissue and it's minimally invasive and you don't have to go to surgery. So I would say to answer your question correctly is that if I was going to treat, I probably would do some form of tissue evaluation, probably through a bronchoscopy, and there's so many options how to do it. But for the boards, I think they will answer the question the way I presented it to keep it simple. Asymptomatic, doing well, probably would just monitor first before committing someone to immunotherapy. Once again, really, I gave you such a detailed answer. I hope you enjoyed that, and that's me.